Hi guys. This is Dr. T. I hope you guys are doing great. Once more, I want to thank you guys for your support. Thank you for liking, for subscribing, sharing the channel. We are growing and we are continuing to grow. So thank you so much, guys. So this week I've started a new rotation. So I'm doing psychiatry now. Yes, I'm excited about it. Um, I haven't done psychiatry in a very long time, but in casualty, I have been seeing aggressive patients that would come into casualty. Those that are on treatment, those that have defaulted treatment, those that have never been diagnosed with any psychiatric condition. So I've been seeing a few psychiatry patients, but ever since I left medical school, it's kind of for the first time now that I just deal with psychiatry patients only. So for the next 2 months, I'll be in psychiatry. So for the first time, we're gonna start uploading psychiatry videos. Yes, obviously we're gonna do that. A patient that I saw, we're gonna do some topics, approach, all those things that we've been doing when I was still doing family medicine. I will continue to do topics from other specialty. I'll still continue to do internal medicine, orthopedics, um, and the likes. So let's talk about psychiatry now. So guys, psychiatry, there's a lot of it's not a secret. There's a lot of English involved in psychiatry. I'm not talking about clinical psychiatry, like when you read textbooks and when you read the DSM-5, there's a lot of English involved there. There are a lot of big words that are there and all of that. So someone who has done, this is my personal opinion and experience. Students that did, majority of the students that did English as their first language, they always do well in psychiatry because it's the English, guys. It's just the English. Not that if you did English as your second or your third language, you won't do well in psychiatry. But the chances of you doing well in psychiatry when you have done English as your first language are very high. Um, yeah. So because even the definitions of the terms there, that's just English, English, English. Um, that's fine. So so what I'm trying to say here is that if you don't like English, if you don't like definitions, it's definitions, 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 definitions. That's what psych is about. Number one. In psychiatry, guys, to do well in psychiatry, there are things that you just need to like just know and understand. First of all, I know this might sound stupid, but it's true. When we think about psychiatry, we always think about psychosis. And that's the first mistake that we do. Not all psychiatric patients are psychotic. There are other disorders that have got nothing to do with psychosis in psychiatry. There's mood disorders, there's anxiety disorders, there's there's um, there's personality disorders. There's a lot, guys. There's a lot, there's a lot. So psychiatry is not equals to psychosis. Yes, there are psychotic disorders. Another thing, psychosis is not always equals to schizophrenia. That's another thing. I know this thing sounds like it's so obvious, but when you come to think about it, you will realize that this is where we mess things up. Another thing is with psychiatry, the symptoms are very, very similar. For instance, let's say the symptoms for psychotic disorders are very similar. And what's going to differentiate? They differ. So what's going to differentiate a psychotic disorder from another is most of the times it's just a duration of symptoms. It's just a duration of symptoms. That's why, like for instance, look at something like schizophrenia. The features of schizophrenia are very similar to schizophrenia. They're very similar to brief psychotic disorder, but the difference there is just duration. So someone does not have schizophrenia if the duration of their symptoms is not more than 6 months. And someone who's got psychotic features, but it's less than 6 months, you need to decide, is it a brief psychotic disorder or is it schizophrenia, depending on the duration of the symptoms. If it's less than a month, it's brief psychotic disorder. But if it's more than a month but less than six months, then that's schizophrenia. So this, like the symptoms for anxiety, they are very similar. The symptoms for anxiety disorders, like your disorders under the anxiety umbrella, they're very similar. But what's going to differentiate is going to be the duration and small other things as well. But the duration becomes very, very important. So which means whatever condition that you study, know the duration of the symptoms. Because like I said, a patient can have features of schizophrenia, and then you say in the exams it's schizophrenia, and then later on you don't understand why you got it wrong, and then they tell you that okay, these symptoms were only there for 2 weeks, so it couldn't have been schizophrenia. And the same thing applies with all the other conditions as well. So be very mindful of the duration in psychiatry. It always makes a person as if they don't know their work, even though they know their work, but it's just that the duration that they're missing out. So that's tip number 2. So love definitions, because in psychiatry they work on definitions, love definitions, and know the duration of the symptoms, um, and also know that so know the umbrellas in psychiatry. What do I mean by the umbrellas? No mood disorders, no psychotic disorders, no anxiety disorders, no personality disorders, so that you can always, when you look at the so know the features of each umbrella, so that when you are given maybe a scenario, you can look at the scenario and decide from the scenario that okay, I think I'm dealing with a mood disorder here, and then you go on and look at the duration, all those things, to tell you which mood disorder are you facing. And also, if you look at, let's say you decide, okay, you think it's a mood disorder, the minute you've got other components like psychotic features, then you know that it's not purely a mood disorder. Then there's also psychotic features. And then you look at, is there a diagnosis that has got a mood component and also a psychotic component in it? If there isn't, then it means that what you're dealing with, it's maybe a major or a depressive disorder with psychotic features. So that's very important. No psychotic features, no symptoms that are related to mood disorders, no symptoms that are related to anxiety disorders, no symptoms that are related to personality disorder, so that you can always quickly decide, okay, is it a mood, is it psychotic, so that you don't, you're not found in between. So it's going to help you a lot. And also when you can pinpoint and say, okay, I'm dealing with a mood disorder here, already you will know, okay, mood stabilizers is this lithium sodium valproate, things like that. Oh, it's a psychotic disorder, okay, first generation psychotic first generation antipsychotic, second generation. So you can always quickly figure things out. But if you think of a patient as a psychiatry patient, you're gonna always struggle. Know that okay, it's a psychiatry patient, but under which umbrella? Is it a mood? Is it a psychotic? Even though sometimes there's some that are just a giveaway. Then there are some there are those that you need to sit down and really read and see the features and all of that. So guys, what we're gonna do, this is just introduction. So what we're gonna do now on my next video that I'm gonna do after this, we are gonna look at psychiatry symptoms, like what makes us to say when we see a patient, what makes us to say this is a psychiatry patient, not psychotic but psychiatry patient. That's different. So because for instance, if a patient comes in, I know why I say it's a CCF patient. I know why I say it's SLE patient. I know why I say this is a trauma patient, because I've seen a couple of things that make me think this is trauma. So psychiatry is not different. So what are the symptoms that makes us to say signs and symptoms that make us to say that this is psychiatry? Then now, if we say it's psychiatry, now we go and dig and see what condition are they having. Like I said, not everyone who's a psychiatry patient is psychotic. There are those that have got panic attacks. There are those that have got acute stress disorder. There are those that have got a post-traumatic stress disorder. There are those that just have a major depressive episode, or there are those that have that's what we should be learning, guys. Then psychiatry will become simpler. So we're gonna do that. So we're gonna talk about those signs and symptoms now on our, it's gonna be our part one. And also we are gonna talk about MSE as well. We're gonna do a video on MSE, which is a mental state exam. I know as students we used to hate MSE. We used to hate, and it's even worse because we used to do the mocha, we used to do also the mini mentals. Those are very long. But here we're gonna do the mental state exam. It's very important. We're gonna talk about the mental state exam. It's very important. There is no psychiatry patient that should be sane, and the thing is, you cannot even make an assessment if you have not done an MSE. MSE is like, it's as important as a PV exam for a gynae. MSE is as important as a scalpel for a surgeon. It's as important as a stethoscope for a cardiologist. That's, a psychiatrist cannot move without an MSE. It's very important. We need to know the MSE. It's just like a GCS. We need to know the MSE. So guys, thank you so much. That's the introduction. So we're gonna do our part one now after this one. Thank you so much. Love you guys.